If I do a case in Pakistan, I do ACT. I don't do ACT that much in UK. My concern here is the heparin, the way the heparin is kept. I'm not sure, taken out from the plane, it's 45 degree outside temperature there, comes in, there's no electricity, it's still the heparin there. So it's not the storage of heparin is important. It needs to be kept cool. So I always do ACT here, if I do a case. UK, we only do ACT if it's really long procedure, whatever. So I think I agree.
Actually,
we are running out of time, so I will just...
actually, we switched to this collection because of this increased incidence of clots in that case. We were not doing the ACTs and the heparin from the best of the heparin companies. That was the Leo at that time. We used that, but that was still, the thing was not improving. And with this enoxaparin, the incidence came down.
Okay, so thank you so much.
You give the you administered the heparin from
I would invite our next speaker,
sheath side or IV line?
Who is Salman Ishaque Shaikh, a fascinating closure.
ये आखिरी है, हमारी सजा भी खत्म हो जाएगी.
So title of my presentation is a fascinating closure. I hope it will fascinate you all, since it's a very deadly presentation. Said fairly simply. To begin with, can we be helped with? So my patient was a 22 years old male with no known comorbids. He had a history of on and off left arm pain for the last few days, basically referred for evaluation of cardiac murmur. His echo done at our institution showed severely dilated LA and mildly dilated left ventricle, EF of 48%. There was a small aneurysm at right sinus of valsalva, and which was ruptured, and with left to right shunt, normal ascending route in aorta. So these are the transthoracic images. Just click it here, play over there. So there you go. The parasternal long axis view is showing dilated right sinus, and the color flow showing continuous flow across the right sinus of valsalva into the RV, consistent with ruptured sinus of valsalva. So this is a CT, this is a static image showing contrast flowing from right sinus of valsalva into draining into RA and then RV, 6 by 6 centimeter in diameter. The distance of RCA from ruptured edge is 18 centimeter. The coronaries were non-obstructive and calcium score was 0, EF of 49%. So we decided to close it percutaneously. With the procedure was done under general anesthesia. Patient was preloaded with DAPT and antibiotic prophylaxis was given. The pre-procedure right heart catheterization was done. Nice decent right-sided pressures, RA pressure of mean pressure of 3, PA pressures of around mean pressure of 7, and wedge pressure was also normal 7. So we did aortic root angiogram in both LA and RA view, showing draining right sinus into RV. So for the procedure, we needed both access. The right femoral venous access were taken 7 French and later on upsized to 8 French. And arterial access via right radial artery 6 French was taken. And through the right radial access, a JR4 catheter was taken, and it was taken all the way to the aortic root. And then from there, it was, and across the defect, it was taken into RV, and through it, a 300 centimeter glide wire was parked into pulmonary artery. I actually don't have all the images saved, so I have And then through the right femoral venous axis, a snare was taken. And So from the right femoral axis, a snare was taken, and through that snare, the park glide wire, which was parked through arterial axis, was snared and externalized through right femoral venous axis. And through over that wire, PDA closure occluder device 1012 was taken, and it was, the procedure was done on a TEE guidance. On a TE, the size of the defect was around 8 centimeter, and so through the right femoral venous axis over the glide wire, the device assembly was taken, and it was taken across the defect to the aorta, and later on pulled back, and device was successfully deployed. And this is the final result. The slight leakage across the PTFE membrane of the device, which obviously gets thrombosed in the next 1 to 2 days. This is a post-procedure echo. Well, on transthoracic echo, there was no demonstration of any VSD, but during TEE there was a small VSD also identified, which was restrictive. So this is the post-procedure echo showing well-seated device with no residual shunt, and there is a color flow across the ventricular septal defect with peak pressure gradients of around 100. It was 1 to 2 centimeters, so kind of restrictive, which of no hemodynamic significance. So my take-home points from this presentation: it's a rare congenital anomaly, less than 1% of all congenital heart defects, and most commonly involves right coronary sinus, about 70%, and followed by non-coronary sinus, 29%. Very rarely occurs in left coronary sinus. Ruptures are more common in males. Surgery, historically the gold standard treatment, but percutaneous closure has emerged in the last few years, and there have been various case reports in which PDA closure devices, VSD closure devices, ASD closure devices, even coils and Rashkin umbrella were used. Residual shunt, new or worsening aortic regurgitation, coronary ostial encroachment, infective endocarditis, and failure to deploy device are reported complications. Number of cases are low, yes, but however, low risk of complications and good long-term outcomes. This makes this percutaneous closure a reasonable alternative for these sort of patients. And I have this. Sorry, this mic just lost it.
Take one.
I have this case report in which there is a series basically in which around 90% success rate of 8 patients did it, and they reported success rate of around 80%. And in previous, and they also give some references of previous studies in which multiple these devices have been used. Thank you all.
Can I ask you an unusual question?
Yeah.
What was your advice to him about oral dental hygiene? This patient risk of endocarditis very high.
Yeah, I think for the first.
Did you really be honest? Okay. Did you advise him?
Yes.
Did you look at the man? How poor oral hygiene was?
You're right. I think pre-procedure, I think we did not, but after the procedure, we advised him that for the next 6 months at least, it should be having.
So important for all valvular heart disease. Please, nobody does it. I don't know why. Even UK a lot of my registrars don't.
Actually, we used to do it in TAVIs, and so that we had done this in this patient also. Yeah.
He's 22 years old.
All right.
Any comments from the panelists?
What do you think?
It's not that high. Yeah, we offered him, but I think we offered this treatment also. He agreed upon this. We have to discuss both options.
I understand there's very high surgical risk or moderate surgical risk. I understand that. Because stable patient, his surgical is low. I'm not sure what the long-term impact will be on the valve itself. Okay, and it's still a small VSD.
Yeah, but that was restrictive and it's around 1 to 2
I
centimeters.
understand. So, my
Spontaneous
feeling
thing,
is
yeah.
surgery
Congenital thing.
would have been first choice in this case, not for every patient.
It's been reported in other case series as well. The patients do have residual VSDs, which are particularly restrictive, and they did well.
But you don't know the other patients.
Yeah, you're right. It's a small case series, and yeah, you're
But
right.
he has zero comorbidity.
In a way, you are right because a small case series, not much long-term outcomes reported, but yeah.
Dr. Saab, the location of VSD, which you say initially it was not seen in it seems to be supracrystal. Am I wrong? Supracrystal. So probably the site which you are saying that these kind of VSTs are supracrystal and only surgery is indicated in those cases, number one. Number two, I'm asking you again, was it spontaneous this rupture of sinus of Valsalva or it was congenital?
No, it was spontaneous.
It's spontaneous. Yeah. So then how that VST was missed during assessment of that spontaneous rupture of
perhaps there was, maybe on 2D imaging there was there, but with color flow there was so much turbulence was there throughout in systole and diastole to it was missed. But during TEE pre-procedure, while we were evaluating the defect size and the relation to the RCA, we did that. We thought over this, but we thought it's kind of restrictive, so it will behave well. So we proceeded with the procedure.
Any comments from the audience?
Excellent case. So I just want to ask you the reason for snaring the wire to the right femoral vein. Why not deploy the device through the aorta?
I think we have to cross a wire across a defect, and then obviously first you devise the aortic disc, and then so we have to put it all the way down. So I think this was a recommended way to do this.
So we have done the coronary angiography, which shows mild LAD disease, and we have taken the heart team on board, and heart team decided total transcatheter approach, in which we have done the coarctation of aorta standing as well as TAVI. Next. So in coarctation of aorta standing approach, we have taken the left radial approach with the 6 French for aortogram as well as for the left subclavian artery, as I have already told you, because coarctation of aorta involved the left subclavian artery. That's we were suspecting might be obstructed during procedure, and we have taken the left femoral vein with 6 French for RV passing, and right femoral approach for coarctation of aorta standing with single proglide. This is the video you can see here, the severe coarctation of aorta. It's very near to the left subclavian artery. That's why we have taken the already rescue from the left radial. Next. This is the right femoral angiogram. In CT scan, there was suboptimal, but here this shows optimal for assess. And in next slide, we are showing the 14 French delivery system, which is passed through the employee's J-tip wire and TPM lead. And next. So here we have selected the stent. We have available the B graft covered aortic stenting, which is on the basis of CT scan measurement and angiographically. We have taken the 22 into 48 mm. Next. Next. So near. So the proximal end of the stent is prop up. Now open, and finally next. Now the disc whole stent is open. Next. After placement of a stent, we have decided to post-dilate the stent with the NC 2340. Next. So this is a post-dilatation. After post-dilatation, we have noticed the obstruction of left subclavian artery. Then we have rescued by engaging the JR catheter through the coronary BMW wire pass. Next. Coronary wire taken, BMW and coronary NC 4.520 taken, and inflate about 20, and we have perforate a few sets of the proximal end of the stent. You can appreciate here, and then finally flow is restored in subclavian artery. Now final shot. This is the final shot, and we have secured the hemostasis by the single proglide. Next. So the TAVI is plain in this patient within 4 weeks. She is on list for TAVI. Next. As we all know that coarctation of aorta is a relatively common congenital heart disease anomaly, and bicuspid aortic valve is a common congenital heart anomaly that may coexist with one another. In adult coarctation of aorta, transcatheter intervention has gained acceptance, but for surgical high-risk patient with aortic stenosis, the use of TAVI has been established. Next. Although the favorable data has been reported for the TAVI when treating bicuspid aortic valve, simultaneously transcatheter intervention for the coarctation of aorta in the bicuspid aortic valve proved to be challenged because of a unique anatomy involved require multiple procedure steps and also a problem of site of access. There are only 3 case reports available in which they have done the coarctation of aorta along with the TAVI. Thank you.
So, looking at the topic of your presentation, I thought TAVI has also done in this case. Probably other people will agree with me because it seems very impressive, though you are planning this and hopefully we want to listen from you in maybe in next conference how it works, because you have to take a lot of, at least 14 French sheaths, jo minimum use bhi karte hain from that area. That's good idea. But I think it's more robust if you have presented both complete procedure. Yeah, thank you.
So my question, I've got a couple of questions here actually. One thing is that when you do a coarctation of a stent, you put the this grafted stent. Do you guys remove the top bit of the graft? Sometimes you can manually remove it to protect the subclavian artery, the covered stent, because it's a covered stent. So remove the top bit of that covered and the top bit to closer to the subclavian artery. The second thing is this, that doing TAVI, because obviously it would have requested more contrast and things, but as my mentioned by the panel, that it will be more exciting. Doing a TAVI in it will be very challenging for you in a sense that this graft nose cone will rub on this. So if you're doing it, give them a few advices. Tips is this, that put a balloon there and use a Linda-Quest wire. So these two will be the tips for the TAVI in this patient. So.
Any comments from the audience?
What were the gradients before and after the procedure?
So before it was 20, and after before procedure was 20, and after procedure was 10 across the grade.
20 and 10.
10, yes.
Do you think this was justified?
What kind of valve you are planning
One
for the
thing
TAVI?
was the patient survived. How old he was?
72 years.
72 years. And a gradient of 20.
Yes, sir.
With this, he survived 72 years.
Yes, sir.
So, was there any justification to do this?
Yes, sir. Actually, she having the multiple visits because of uncontrolled hypertension in different hospitals, and also she has history of shortness of breath multiple times, and she has also history of syncope 3 to 4 episodes. That's why. Yeah.
She has aortic
Aortic.
But sir, uncontrolled.
I was not sure that it was part of pseudochrome. But again, the CT will tell you better. And I agree that 72 years old, I'm not sure. Okay.
Yes.
Excuse me.
Thank you.
What kind of valve you are planning for the TAVI? As it is a
planning for
bicuspid aortic valve.
accurate new 2.
Sapien?
Which hospital
Edward
are you
Sapien?
from? You're from Gumbet, aren't you?
Yes, sir. I'm from.
Accurate new 2 for this one.
Yes, sir.
Edward Sapiens?
I will give you my mobile number. WhatsApp me, okay? Yeah.
Excuse me, can I ask?
The new two nose cone is not that friendly, so.
We don't have SAIR card.
Oh, no, but say, send it to the Medtronic Center and ICVD, because Neo 2 is not very good for this. It will rub.
There are few data we are using in.
But Neo 2.
We have done the 10 cases.
No, I'm not saying about bicuspid. The valve, when you rub it with the valve which is there, the Neo 2 will push against this valve which is there. Yeah.
Is the latest.
Yeah, but that will push on the valve which coarctation stent which you have. The nose cone is not that flexible of it.
Yes, sir. We have done 10 cases. And
With the coarctation stent.
Not coarctation, with TAVI.
Okay.
Sir, I want to ask a question and want to learn from your experience also. These procedures, they require relatively larger French sheath, and most of the complications, they are related to access site. My question is, if they are going for relatively bigger size access site for coarctation treatment, can we plan such case, like his case, in a single go, to go for coarctation and TAVI in a same time?
That's a good question. It is. I'm sure you guys would have used ultrasound guided technique. I don't agree with the single ProGlide with 14 French, because you would have to put a manual pressure there and you might develop aneurysm and it might not be workable for the future. So I might have gone to make it more exciting. I would have done the TAVI and the coarctation at the same setting actually for this patient. But just for the adrenaline rush probably more than anything. If the coarctation was needed. No, there is none. No.
If coarctation and this was to be done at the same time, so there are pros and cons of doing the coarc first and the stent, the valve first. If you do the coarc first, the stent can get stuck in the coarc stent. On the other hand, if you do the valve first, you may increase the gradient across this, if this was a significant gradient. So that can put the patient in flash pulmonary edema on the table. I agree. This will be the problem even if he goes again at a later date, 3 months after this, or maybe on the same. So one should be on the guard that this the valve can entangle in the stent.
Hello, I have a question.
Symptoms were mainly aortic stenosis.
Exactly.
Syncope, chest pain, mostly really. It's not coarc symptoms, mainly aortic stenotic symptoms.
So what sir was mentioning, is that correct, that a coarctation can be there, but I think your question about the excess complications, yes. From that perspective, yes. From what sir has mentioned, exactly you were to. I used to do internal carotid artery TAVIs in UK. This might be the case where you could use it. It won't rub against anything. It will go. No, carotid artery. Carotid artery TAVI. So you won't rub through anything. You will just go straight into the valve.
I have a question from panelists. In such case where we have severe aortic stenosis and with this coarctation of 20 mm G gradient, then is it the best good option to opt for TAVI first and then wait for the symptoms?
That's the whole discussion.
Yes.
Yes.
Either simultaneous or TAVI first and the coarc first. Obviously, if you can go across, it's different. Obviously, I still believe more of a problem was a stenosis rather than the other coarc.
There can be a flaw in the gradient, and there is no pressure from behind. So that may give you less gradient.
The most important,
so
the thing
this is one of the flaw in this case. If there is severe aortic stenosis, there is no pressure coming to the before the coarct. So this may be giving a false. But as the patient was surviving with this till this age, this again go into something like against this gradient.
But this patient has gone, to multiple hospitals for last 3 years. For this symptom, because the surgeon has declined every time. And this was high risk, for them. And putting, for example, doing the coarctation of aorta first, because if you do, for example, upfront, TAVI and the coarctation, we would have slipped the coarctation, the stent forward and putting, for example, the patient in danger. That is, the one case report is there. They have done simultaneous, not in one setting. They have done it, in 2 settings. This is the most important thing. Either you go, for example, the other way around, you can go. This is, to give, for example, to relieve the symptoms of the patient. Sure. Yes, you are true, for example, for the accurate new, the bicuspid valve is not, for the bicuspid valve, is accurate new is not good. But the current data with the accurate new 2 is, coming up, that is, for that, bicuspid. It's still, this is not good. The sapien is, the other, supravalvular
I will share the data with you. There's no data. Only Medtronic has got data on the bicuspid, and I'm 100% adamant on that. No other valve has got data on the bicuspid.
I think we are out of time. And thank you so much for all of you for patient listening, and thank you so much for the panelists.
With this, we are going ahead for the final session of fellows cases. Please be seated. And we have got 6 more interesting cases to go. I will request Professor Tariq Abbas to come here and take the mic as the moderator of the next session.
Ashraf. Without wasting the time, I think we already ran short of time and behind the schedule. We should start our final 5th session of this fellow. I would like to invite the panelists on the stage first, and then we will start calling the doctors to present the cases. The panelist of today's final fellow case sessions is Shamim Siddiqui Sahab. Is there? Shamim Siddiqui Sahab, please come to the stage. Akhtar Bandeshah Sahab. Ahmad Fawad Sahab. Dr. Ahmad Fawad. Dr. Kashif Hashim Sahab. Colonel Asif Nadeem. Naeem Malik Sahab. Abdul Sattar, Abdul Salam, and Dr. Shoaib Daniel. Dr. Shehzad is Aslam. Dr. Shehzad Aslam and Dr. Kashif. You please come to the stage. Dr. Khurram, please come and join us at the stage. Dr. Khurram, Dr. Numan, you please come and join to the stage also. So the rule of game, the case, the first case, and then.
So, as before, each presenter will be given 5 minutes for the presentation, and we are cutting short the discussion time to 5 minutes because we are running short of time, and there is going to be general body meeting at 6 o'clock. So there will be 5 minutes to the presenter followed by 5 minutes of discussion.
The first case is a hybrid card for the complex retrograde CTO. Presenting the presenter is Mashallah Muhammad Anjum.
Bismillahirrahmanirrahim. Assalamu alaikum. Without making further delay, we'll start our presentation. Okay, this is a 37-year-old male smoker, non-diabetic and non-hypertensive. And you can see in this view that he had anterior STEMI 1 year ago. On regular medication, now presented with a non-STMI. And you can see the circumflex and right coronary artery, their normal RCA is dominant. There's a tight stenosis at the origin of the ostial LAD followed by a total clean. And entire of the LAD is that being filled from the RCA. So this was a CTO LAD. These are the views. Single vessel CTO LAD, J CTO score was 2. The syntax score that was 18. An option for PCI and whether cabbage was discussed with the patient and the family. The cabbage was declined by the patient. Because he was 1 year ago, he was already advised cabbage, and now he opted for a PCI. Risk and benefits were explained, and a dedicated approach with dual access was taken for doing this LAD CTO. You can see we initially selected an antegrade wire escalation strategy. For that, pilot 50, then 150, they were used but we failed to puncture the proximal cap. Pilot 200 was also used. It punctured the proximal cap but is not able to track into the distal true lumen. Followed by that, the Gaia 2 was taken, and even the Gaia 2nd could not cross into the distal true lumen. And you can see there were large septal branches as well, and these wires kept on going into the side branches or into the subintimal plane. So at this point, either there was option to, go for other subintimal approaches like subintimal dissection and creating a long dissection using knuckle wire, or using a stingray balloon, or there was possibility of doing a retrograde approach. And you can see there were large septal collaterals in the last view. So we opted for going with a retrograde approach. And this case, you can see there's a large septal 1, large septal 2, and both of them have shown, that there are good sized septal collaterals over there. Can you show the slide, please? So you have to run again to the, okay, this one. For that, AL1 guide was taken from the radial approach and XB was taken from the femoral approach for antegrade access. And you can see from retrograde side, a whisper wire on an OTW 1.5 mini track balloon is able to cross into the septal artery and going into the distal LAD. Next, various approaches from the retrograde was tried, and there are a lot of views, but we have shown on only the relevant one. You can see, first of all, the retrograde puncture of the distal cap was tried, but it failed with the pilot. So retrograde wire escalation was selected, and the Gaia second, again, another Gaia second that was taken and that was able to puncture the distal cap, but this Gaia second could not cross into the distal true lumen. You can see both of the wires, one in the antegrade, one retrograde guide, but none of them are up till now into the true lumen. The next slide, we first attempted card with a balloon expansion on the proximal wire on the antegrade side, and the retrograde wire was tried to get into the true lumen, but the card failed. Then we tried the reverse card with the balloon on the retrograde wire, which failed as well. So at this time, we tried for the confluent balloon techniques, which is inflating one balloon on the antegrade and one on the retrograde wire, and to create a confluence of the lumens at this point. And luckily this became successful. And in the next view, you can see the antegrade wire that is crossing and tracking into the distal true lumen. You can see on this side of the screen going straight away into the distal LAD. Up till now, the procedure took almost 1 hour and 30 minutes, and from now onwards, the procedure was relatively simple because we had got access into the antegrade true lumen. The antegrade, a balloon was placed on the antegrade wire and inflated to check the distal true lumen entry, followed by the retrograde wire that was gently removed on the OTW balloon still in place. The retrograde equipment was also removed, and after antegrade balloon dilatation on 2.0 and 2.5 NC balloon, you can see that there's a good flow into the distal LAD. So following that, the drug-eluting stents of 2.75 and 3 were placed in the LAD, and this was the final result. The total procedure time was 300 ml, and there was no side branch loss. All the septals and the diagonals, they were intact. And we took 2 hours to complete this procedure. So, any questions from the audience?
How much was the flow time?
The total procedure time was roughly 2 hours, and the fluoro time was almost 40 minutes in this case. And in most of the areas, you can see we use the safe fluoro rather than doing the cine, as was shown in this presentation as well.
What was the grade of collaterals in this case?
Sorry?
Grade of collaterals.
Okay, you see in the septals, first and septal 2, there were good sized collateral. The septal 2, we made the choice of selecting the septal 2 collaterals because this was a CC3 and it was a rent rope grade 3 collaterals. So that means a collateral which is roughly around 1 millimeter, and crossing the retrograde balloon or microcatheter is very easy on these collaterals.
Was there any role of IVUS to
penetrate the true lumen? So when the antegrade wire escalation strategy and subintimal techniques they were failing, there can be role of IVUS which can be placed in the proximal LAD and guide us to enter into the distal true lumen. And its role is more important when there is an ostial flush occlusion, because we had punctured the proximal cap, so that's why we didn't consider using the IVUS at this point. If we were not able to do the proximal cap puncture, then IVUS would have been the ideal choice.
Excellent case, Dr. Anjum. One question, what microcatheters were you using
Okay,
actually?
that's a very relevant question. We do have Corsair and we do have this fine cross on the board for these retrograde approaches. In this case, we first went with a 1.5 into 8 mini track Abbott balloon. The reason is it's very slippery and trackable. It has a coating. The other reason is because the septal was large, so definitely the cost is also low on that. And if we need to even dilate the septals, we can do a dilatation for putting in the larger balloon. So I selected a OTW balloon in this case.
Okay, thank you.
Okay, I think that's all. Any question from the audience or?
Thank you very much. Thank you, Dr. Anjum. Basically, it's nicely demonstrated the very complex procedures like cart and reverse cart and knuckle techniques, and in a very short time. I really appreciate Dr. Anjum that he has done a long case and presented all 3-4 techniques which will be used during treating antegrade and retrograde, and then cart and then reverse cart and then modified cart. And he described this very nicely and succeeded the case. So the next case of today's is a calcified LAD with stent dislodgement and its management. And the presenter is Muhammad Hashim.
Assalamu alaikum everyone. And, I must congratulate all of you that it's very good weather outside, but still you people are here from morning to learn from each other's experiences. So my name is Dr. Muhammad Hashim and I am from Dow Institute of Cardiology. The topic of my case is stent dislodgement. It is, whenever you go for complex case, you must be prepared for all the complications that you can have in cath lab to tackle that. So my case is 52-year-old gentleman. Yeah. Okay, I will explain the data that my case is a 52-year-old gentleman. He has smoking history, 20 pack years of smoking history with no other comorbids. He presented to one center with a complaint of chest pain, and he was diagnosed as an inferior wall MI. On diagnostic angiogram, he had 3 vessel coronary artery disease with total occlusion of RCA. So initially RCA was fixed as a primary PCI. Then in index hospitalization, stage PCI to LCX was done. After that, he was assessed that for LAD was diffusely diseased, having high calcium. So he was referred to us for this plaque modification therapy and for PCI of LAD. So this is the diagnostic angiogram. It is not getting played. First view chalaiyega please. So the LAD is diffusely diseased and highly calcified. So we had IVUS, pre-intervention IVUS, which showed 360-degree calcification in LAD. So it was decided to have ROTA with ROTA Pro 1.75 BER. So we did ROTA in LAD with 1.75 BER catheter. And then there was a disease in diagonal, but it was decided to have provisional stenting of LAD, keeping wire in diagonal artery. So then we will decide what to do after stenting the LED. What we did rota in LED and then pre-dilated the LED with, after rota, pre-dilated the LED with 3012 or 3015 NC balloon. After having after pre-dilatation, we have taken 3028 mm stent to have stenting in distal disease. While taking stent there, the stent was not getting there, getting there in the crossing that lesion. What happened? The stent get dislodged, and while having dislodged stent, we tried to pull up the stent in our catheter, but the proximal edge of the stent get distorted. The proximal stent of this stent distorted, and it was not coming in our guider as well. So there was a wire in both the diagonals. So we took out all the system out. Unfortunately, there you can see the proximal edge of the stent is distorted. Unfortunately, we were not able to took out the stent in our guider. What we did, we took out all the system out. And while taking out the system, what happened? All the wires and the stent balloon came out, but you play please. But the stent was in diagonal artery, subclavian artery. So with the help of this snare, we grabbed the dislodged stent, retrieved the dislodged stent, and then we again have engaged our guider. So we again wired both the diagonals and the circumflex artery. Now we again both pre-dilated with cutting balloon, 3-5 cutting balloon from the distal segment up to the proximal segment. We able to wire the diagonal. Here it was decided that the diagonal is badly affected and there was hematoma as well. So we first stented the diagonal, keeping some struts in LAD, and then we rewired both the diagonal and LAD with 2 stent strategy, that is mini clot. Then what we did part the proximal edge of the stent, opening the struts, and then we deployed another stent in distal disease segment. And then what we did is we did another stent left main to LAD, overlapping with previously deployed stent. And then we had a pot with 5 mm. Left main to LAD was stented with 5.0 NC balloon. And we did KISS in the distal LAD to diagonal stent as well as left main to LAD and circumflex. So this is the final shot. My take-home message is, even with your preparation of cath lab, we were suspecting that this is a calcified lesion with rota pro. We were able to manage this case, but again and again there was a complication. We were fortunate to tackle that complication, but even with your high-tech cath lab, you will have complications. So be prepared while you take complex cases. You can encounter any type of complication. Thank you very much.
What was the burst size initially?
The burst size was 1.75.
Could we upgrade the burst size?
No, we didn't upgrade the burst size. We did after having rota, then we did pre-dilated with NC balloon, 3012 or 3015 in high pressure, and there was no indentation in pre-dilatation. So we thought that we were able to deploy the stent, but unfortunately that was not the case.
When the stent was not crossing, did you think of guideliner used
Then
at that
after
time?
initially, it was the pre-planned. Then after the stent get dislodged, then we deployed all the stent, the diagonal stent as well as the distal stent, the distal LAD stent, and the left main to LAD stent, all of these were deployed with guide extension catheter.
Okay, good. Another question.
Done during?
Yes, due to lack of time, I wasn't able to put the slides of that. I was pre-PCI and post-PCI, we did IVAS as well.
What was the finding in post-PCI?
Post-PCI, there was optimal luminal area, but pre-PCI, there was a highly calcium, 360-degree calcium throughout the LAD.
Before removing all the equipment from the artery with this large stent, did you think of any ping pong like to secure the main vessel at that time?
Actually, we were not, we were underestimating that calcium. So we thought that with rota of 1.75 Burr and with then pre-dilatation with 3O NC balloon, we will be able to cross the lesion. That's why we didn't thought that, and that unfortunately we had this complication. Sorry? Yes, it could help us post-rota. Yes, post-rota IVAS could help us, yes. But we didn't, post-rota we did NC balloon with 3O. So, and there wasn't any indentation and the balloon was crossing very easily. So it was our thought that the flag modified and we will be able to cross the stent.
And what was the size of LED pre-rota?
Pre-rota, the size of LED, distally it was 3O and proximally it was 3.5 or 4O. We post-dilated with 4O and left main was post-dilated with 5O. Pot was done with 5O balloon. You're welcome. Thank you.
Thank you. Nice case. And that shows that after all preparation, you still be prepared for some disaster in cath lab. Nicely done rota, nicely done pre-dilatation with the non-compliance balloon, and still they stuck with the balloon. So anything can happen in the cath lab. So be prepared for that. So whenever you are planning a complex cases, you do a run of angioplasty in your mind. And definitely you also think about all the complications and the way out. And the plan 1, plan A, plan B and plan C in your mind also. And whatever happens, you sit and then think about that and plan that. The ping pong technique, securing the main vessel, it would have more disasters if you taken out all the things and then vessel block at that time, and that will be very difficult to rewire that vessel in the setting of calcification, in setting of rota ablation, and in setting of doing a pre-dilatation with NC balloon. So we are moving to the next case, and the next case is by Zubair Ashraf, crushing of left main bifurcation.
Assalamu alaikum. I am Dr. Zubair Ashraf from Bahia International Hospital, resident cardiology. Today I am going to present a case of crushing of bifurcation of left knee. My patient is a 74-year-old. Known case of diabetes, hypertension, and previously he has ischemic heart disease, and recent 1 month back ischemic CVA. Recently had non-ST elevating MI and pulmonary edema. Echocardiography was done, which shows normal ejection fraction, no wall motion, and valvular abnormalities. So we take the patient to the cath lab after stabilization. Coronary angiography was done. Kindly, you can play the video, please. Which shows severe left main disease involving the ostia of left circumflex and left anterior descending artery. There is also disease of absolute marginal branch and diagonal artery. Right coronary artery show minimal disease. So we referred the patient to a cardiac surgeon, and he met with the cardiac surgeon. Cardiac surgeon offered him a coronary artery bypass surgery, but after the option, he met with another cardiac surgeon. and a neurologist. Then he opted the left, high-risk left main PCI. So we use the gel 7 French guider to engage the left main. We place the run-through wire in LED and left circumflex. After that, we did sequential ballooning of LED and left circumflex. Then we make sure the optimization of the strand in LED and left circumflex. First, we deployed the strand in left circumflex, which is 2.75 14 millimeter at 12 atmospheric pressure. Then we pull the balloon a little bit behind and flare the ostia of left circumflex strand at 18 atmospheric pressures. Then we pull the wire and balloon out from left circumflex. After that, we deploy the strand in LED. Then we pull the balloon again a little bit behind and crush the left circumflex strand. After that, we did the IVA study of left main for the strand optimization and understanding of. This is the IVA study of left main from LED to left main. During the after the IVA study, we measured the area in left main, which came out to be 4 millimeter squares. Now we are entering the left main. Now in the aorta. After that, we rewired the left circumflex without any difficulty. And we did the port with NC 8 into 10, 4 into 8 millimeter just before the ostia of left circumflex. We inflated the balloon at 16 atmospheric pressures. After the port, we did kissing inflation in left circumflex and LED with 3.25 stunting, 3.25 balloons. Then we again report the left main. Again, we report the left main with same balloon, 4 into 8 millimeter square at maximum atmospheric pressure, 18. So after doing that, in next, can you play the next video, please? These are the final results after doing the port. And we did the IVAS of left main again. During re-IVAS, the areas improved from previously 4 millimeter square to 11.2 millimeter square.
जी सर.
From this whole scenario,
जी सर. तो ये सेशन शेयर कर रहा हूँ ये शीश महल 2 में.
my take-home message is IVAS is helpful, especially in left main cases, high risk, to optimization of the stunt. Thank you. Any questions?
When you did IVAS, the stunt in the left main was is a little bit under-deployed.
Yes, a little bit under-deployed.
So you should rewire the circ first, or you should port first, the left main?
We rewire the circ first.
Okay. But you should do port first, so that it should be deployed well, and then you rewire the
Yes.
circ. Okay, good. Great.
Thank you. No more questions?
Any other comments or questions about this presentation? Because always define this technique is a mini crash technique. What is the difference between mini crash and decay crash?
During the port, the first was 18 atmospheric freckle, the second port is at 20 atmospheric pressures. Okay.
So for the final port, you need a higher pressure for prolonged period of properly, not in a elliptical shape, rather in a rounded shape, the final portment is to reconfirm the stand after doing this final kissing also.
So when we do the second port and do the IVUS, stand was very optimized, and the area is increased 11.2 millimeters here as well.
Any other questions or comments on this case?
Was the ostial circumflex stent was fully deployed in the final IVUS study?
Yes, we did the IVUS of left circumflex as well after doing the second port as well. So it was fully deployed.
Yes. Yeah, definitely. The IVUS should be done before, because a lot of information you can get by the basic IVUS study before starting and before planning your strategy, selecting the length of the stent, selecting the size of the stent and the diameter, and definitely if you need some debulking mechanism, whether through cutting balloon or through rotablation, all information we can get if we do the IVUS beforehand, before planning or before forwarding this situation. Thank you. Definitely, the post IVUS is helpful in optimization of your procedure, but for planning of procedures, you have to do the IVUS beforehand. Thank you very much. So the next case is the presenter is Amna Farooq Janjua, the complex PCI of left main stem coronary artery.
Good evening, everyone. I'm Dr. Amna Farooq Janjua. I'm a cardiology resident at Liaquat National Hospital, Karachi. My case today is about left main coronary disease, which is a commonly encountered clinical entity, yet management of left main disease in acute clinical setting continues to pose itself as a clinical dilemma and apprehension. So our patient was a 75-year-old diabetic and hypertensive, a known case of COPD with an active smoking history of 39 fat years. He presented to the ER with the complaints of chest pain, diaphoresis, and shortness of breath since last 4 hours. The patient was in a stable state of health at home when he started experiencing these symptoms. The chest pain was typical, it was associated with profuse diaphoresis, and had progressively worsening shortness of breath. For these features, the family brought him to the ER. At presentation in the ER, the patient was conscious but was progressively deteriorating with a pulse of 140, which was steady but regular. His blood pressure was falling and he was desaturating. This was his ECG done in the ER, which actually shows LVB. We did not have a previous record to compare with, so we did a bedside echo, which showed, So this showed severe LV dysfunction. On these bases, we diagnosed the patient as a case of ST elevation MI equivalent. So it's moving on its own, I'm sorry. So we diagnosed the patient as an ST elevation MI equivalent with cardiogenic shock. Patient was initially managed in the ER. He was put on inotropic support, electively intubated, and then moved to the cath lab. In the cath lab, he was approached by a femoral approach. As you can appreciate, his RCA is showing an ostial lesion of around 90%. We noticed pressure damping in this, at this point. And his left side was accessed, which basically revealed a significant left main lesion. Can you play this, please? Actually showed a significant distal left main disease. I'm sorry, I don't know why it's not playing. Based on the angiogram, we calculated patient syntax, we took a heart team approach, and it came out to be high syntax, but because of the patient's COPD status, we decided on going ahead with PCI. So before starting the PCI, since patient was in cardiogenic shock, we took patient on intra-aortic balloon pump. We decided on starting off with RCA ostial fist because then we'd have better support for our left main. And then because of the acute clinical deterioration of the patient, we decided on going ahead with provisional stenting. So we started off with the PCI of RCA. We pre-dilated it with 2.510 SC. We stented it with 3013 Zyne's expedition, followed by post-dilatation, resulting in adequate opening of the RCA ostium. Next, we moved on to PCI of left main to LAD. Now you can appreciate the distal left main disease that we were unable to see earlier. So we wired both the vessels. We pre-dilated it with 2.510 SC, but that resulted in inadequate pre-dilatation, so we used 3.58 NC instead, followed by stenting it with 3.533 Zyne's expedition. At this point, the wire from Circ had come out, but patient was running ill-sustained VT, so we did not try pushing the wire back in, but we moved ahead with post-dilating it with 4.58 NC. As you can see, this resulted in complete occlusion of the Circ. So we tried to immediately rewire Circ at this point. We were fortunate enough that happened without any problem. We did a kissing balloon inflation with followed by POT, and then this was the final result. We did realize that the Circ ostium was pinched here, but patient was clinically not that stable. So we tried to call off the procedure at this point, move the patient to the ICU, where he remained on IVP and ventilatory support for the next 48 hours. He was extubated 48 hours later, and his EF had actually improved before discharge. We did a cardiac rehab, and the patient got discharged on the 5th day of admission. He came to us with a follow-up 2 weeks later with improved functional class and without any residual symptoms, actually highlighting the fact that PCI done in less complicated left main disease in this new era with better stent technology can result in expeditious procedure with fast recovery in patients. Thank you.
Ask you a question. Okay. Thank you very much, Dr. Amna. To start with, your initial diagnosis was left system.
It was ST elevation, that was the diagnosis.
Yeah, but that was left-sided, or?
So you see, the RCA ostium was also involved, and left main was not 100% included.
As per echo, you had shown.
Yes.
What do you think? Was there left-sided ischemia or right-sided?
Would be obviously left main because it was.
Why did you approach right first rather than?
Because I mentioned
the patient was quite unstable. You had to put in an IABP, and in someone you are having wall motion abnormalities in the LAD territory, and you are doing right first.
So it was not LAD territory, it was diffuse hypokinesia. Secondly, as I mentioned, that going with RCA ostium gave us a better support, for left main too, because this way we'd have at least something to back us off. There was not 100% occlusion of any one vessel.
Yeah. Well done. Very good case. I like the provisional stent here, and very well done. The only I want to say that you did pre-dilatation by 2.5 balloon, right?
Initially, yes.
So, but after that you sent a stent, 3.5 stent. After that.
We used 3013 stent.
Trio is it was. No. I'm talking about the left main.
It was 3.533.
Okay. So for the left main, 2.5 may not be enough. If you have a calcification, 2.5 may not broke the calcium, so you might have under expanded stent. So at least you should try with the trio, even 3.5. That's a very important point. 2.5 sometimes you see that it's opened but not, right? So for the left main we have to be very careful, or proximal LAD. But I like how you do pre-dilatation and then pods and reports. Very good. How did you do kissing? 3.5 for LAD and then
2.5 for CERT.
all right. Okay. Very good.
Very good presentation. Actually, I was doing this case. My name is Dr. Kaleem. Initially, it was very difficult to put even 2.5 balloon in the left main. As long as Kashif, your question is concerned, why I adopted it's a global hypokinesia. There was a TIMI 3 flow in LAD also, and circumflexes also. So left main is heavily calcified, and there are a lot of chances of complications. LV is very down. I put an intra-aortic balloon pump. So I plan to start with as maximum support as possible. So I start with the RCA. It looks to be a bit simpler. So then I switched to left main. Initially it was 2.5 balloon because of already inflated balloon. It was having very difficulty to go through the bifurcation of left main. But then I got a 3.5 NC balloon and high pressure pre-dilated. And then extended.
Very good point. Because you see that it's calcified, even 2.5 balloon didn't cross easily, so you thought that there is a heavy calcification. Very good point. So you did 3.5 pre-dilatation.
Pre-dilatation, and then 3.5 NC balloon, which I used in RCA. I pre-dilate left main also.
Okay.
With a very high pressure at 24 atmosphere. It was balloon was well inflated. Then I put a stent. But at that time, actually, wire comes out. Patient has got a non-sustained VTs. He has got a high inotropic support. There was a TIMI 3 flow in the circumflex. So I do not worry about that one. Once I put a stent and make a pot, there was a TIMI 0 flow in the circumflex. I just quickly wired that one and just giving a kissing balloon and then pot again. And it will give a very good response. After 48 hours, patient got out of the ventilator, IBP support, and he has got a very good recovery in the hospital.
If the lesion in the left main remains undilated, then you can try the rotablation as well in the acute setting.
Actually, there was so much clinical complexity, so unstable patient. And the NC balloon, there is a very good inflated, and it was post dilated with 4.5 at 24 atmosphere. It looks to be a very good results. So I do not use a rotablator. Generally, we will come out of this calcified lesions with NC balloon because of better availability. If it is undilatable, then I will consider that one.
And what about the cutting balloon?
As I say, there was a good result of NC balloon. So I do not require to use a cutting balloon or something. And patient was so unstable, so I have to quickly do all that procedures. And every step looks to be favorable. If at any step, if it is not working, then I proceed for further one.
Thank you.
Thank you very
much. Excellent case. I think the one question is that should we go for provisional stunting tap in the circ, or we should accept this result?
I think the result is good for me, so provisional, very good choice here. After kissing, we have good result.
But what is the routine cases? If in routine cases, if we have good TB3 flow in non-dominant circ, should we dilate or
No. No, if you have a good result after cross stent, you can leave it on after pot. Yeah.
If you're satisfied
you don't have to mandatory.
If you're satisfied with the flow,
yes.
you should not touch that.
Yes, you can.
Instead of calling more and more complications like damaging the ostium of the cell by ballooning or by kissing balloon technique.
True.
So the next case.
बस वो ज़रा निकलने की कोशिश किया ठीक है वो मैंने सपोर्ट ले लिया बड़ी ज़बरदस्त
Successful retrieval of fractured coronary balloon, and the presenter is Abdul Salam Majeed.
Thank you very much. Assalamu alaikum everybody. I am Dr. Abdul Salam, an interventional cardiology fellow from Tabba Heart Institute, Karachi. And I'll be showing you a case in which we have successfully retrieved a fractured coronary balloon, and that was in the setting of a CTO PCI. So I'll start with the name of Allah. Bismillah ar-Rahman ar-Rahim. So the case is of a 74 years old gentleman who, a 74 years old lady who has a good functioning status. She is known case of diabetes, hypertension, and she has history of depression. She presented to the clinic with history of exertional chest and arm pain, CCS class 3 for 2 weeks, and 2 episodes of similar pain happened on rest the day before. Her ECG, which was done at the time of the having the symptoms, it has shown lateral ST depression. So she was admitted electively for coronary angiogram. So this is the coronary angiogram. This is the coronary angiogram. If we see the first clip, it's showing the caudal view. Can you please just play it one by one? Yeah, just one by one, please. Okay, so in the caudal view, the circumflex artery actually is visible and there is no obstructive disease. From the cranial view, we can see the LAD, which is occluded immediately after a very large septal branch, and the rest of the LAD is filling in a retrograde fashion through left-to-left collaterals. So this is RCA, and the distal segment, there is like mild to moderate disease. And on the LV gram, we can see that the LV systolic function is normal, and the EDB at that time was 19. So we have decided to proceed with the PCI to the LAD. So we have taken the help of a microcatheter, and the LAD lesion was crossed with Gaia 2. Initially it went subintimal, but later we have succeeded in wiring the true lumen. We had the microcatheter which we have advanced to the distal vessels, and we have taken the Gaia 2 back. And since the microcatheter was there, we have taken the advantage of that, and we have given a small injection, and we have confirmed that we are in the true lumen. So as I have mentioned earlier, the Gaia 2 has been taken out, and we have replaced that with a workhorse wire to be more safe. We have also wired the large septal branch because we didn't want to lose it. And the LAD lesion was initially pre-dilated with the 2O balloon up to 16 atmosphere. So subsequently, we have also ballooned the ostium of the septal branch with the same balloon up to 6 atmosphere. And this is how the LAD looked after pre-dilation. So we start the stenting, and initially we have deployed the 2.5 by 38 regulating stent from the mid to the distal LAD at 12 ATM, and subsequently we have deployed 3.0 by 26 dis in the proximal to the mid LAD, which was distally overlapping the previous stent. Then we started post-dilation. So the distal stent we have post-dilated with the stent balloon of the proximal stent, which has a diameter of 3.0, and we have went up to 18 ATM. The proximal stent was post-dilated with 3.75 NC balloon up to 20 ATM. We had some difficulty when we had to deliver the balloon in the proximal stent. And unfortunately, it's not playing the way it's supposed to, but this was the LAD immediately after post-dilation. If you can appreciate over here, though it's moving slowly. So in the proximal LAD, where the stent is, actually there is a pinch over there. We thought that the stent is under expanded. So we have taken 3.5 NC balloon, but it was a shorter balloon, a focal one. It has only 8 millimeter length, and we have taken it again with difficulty to that portion which was pinched, and we have inflated up to 26 atmosphere. And subsequent angiogram is just in front of you, so there is no significant improvement. That area still doesn't look nice. So for further expansion of that, we went to a very high pressure balloon, which was the OPN. It was 3.5 in diameter and 10th by length, and we have inflated up to 35 atmosphere. And here's the interesting part of the story. So we have inflated after that, as we do, which is deflated the balloon, and to take the subsequent angiogram. I was just pulling the balloon, so I had some difficulty. The balloon was not coming out. Apparently, it has stuck in that area. So we have deflated more because it's a big balloon and it has a high pressure. So deflated more. I have just pulled it more with more force, and there was initially some resistance, and suddenly I felt that the whole resistance has gone and the whole shaft just came out in my hand. So for a moment, it was fine that we have taken that out, but my eyes are on the monitor. So the shaft came out, but the balloon actually is still there. So the balloon came just back from the LAD to the left main, and as we see, the balloon just stuck somewhere between the tip of the guiding catheter and the left main, while the shaft actually came all in my hand. Again, for a second, I didn't know what happened. Luckily, my mentor was just beside me, and he was like, the balloon is not coming out. I said, no, actually, it came out, but it didn't, it didn't come out. So the shaft is there, the balloon is there. He told me, okay, so basically the shaft of your balloon has fractured. So we had a complete dissociation between the proximal and distal part of the balloon. So balloon is there at the tip of the guiding catheter and in the left main, and we have no control in that balloon. So what we thought we'd take another wire just to take it out of the tip of the left main. Okay, take it out of the left main, take it to the coronaries. Then we have lots of options, to retrieve that. But unfortunately, that balloon was partially inflated and it was occluding the tip of the guiding catheter, so we could not do that. To create some space for the other wire, we had just to pull the guide slightly back. We did that, but the guide came out, balloon came out, and as we see in the last picture, so the whole balloon and the wire actually just rocking in the aorta, and we don't have any control or approach to them. Lots of options came in mind, but we started with the snare. So we have taken a small snare over there, and we have succeeded in getting hold on the whole balloon and the wire, and the whole assembly was pulled back in the guide, and the whole guide was taken out. We have flushed the guide. We made sure that there is no fragment of the fracture shaft is over there. We have re-engaged the left main, and this is the final shot. So luckily the left main is intact, LAD TM3 flow. We were happy with the result, and with this, I'll thank you very much, and I am ready to answer any question. Thank you. Yes, please.
Very nice case. Do you think a partially inflated balloon, which you try to, with very great resistance, try to get it out, ostial LAD doesn't look to be a good one, slightly diseased, and distal left main also some tapering. Would you not wire it again and do an IVS? Is there any injury caused by that balloon or not?
After all what happened?
Yes, after.
Not really. So I think we have to see the angiogram. Angiographically, it looks fine. The left main, because again, you are very right. Actually, it was partially inflated. It was in the left main for a long time. So we worried about dissection and all. Patient remained stable, asymptomatic. The ECG was fine, and the angiogram was also okay. We decided to stop over here. And the only thing, the whole cath lab staff wanted me to bring a sweet for them for the success of taking this balloon out. Any other question?
So you couldn't send the second wire to.
Not because the balloon was occluding the tip of the guide catheter.
Okay, where is the broken side in the distal of the balloon? Where is the broken side? Do you know it? Is there any piece of the balloon in the catheter?
Yes, actually, when it came out, actually parts of the shaft was still there. It
Okay.
was not only the balloon. Around 2 centimeter was already there with the balloon, and the rest of the shaft came out.
Right. In that case,
that was not visible, even actually with cine. So we were not sure.
You can't see it,
Maybe
yeah.
trapping that at that time was a better option.
so yeah, so I would say that you would trap the balloon
But
at
we
the
were not
distal.
sure if the shaft is there or not.
But you will feel it when you remove it. If the balloon is calm and wire is coming back, so it means that you trapped it. Yeah.
For me, it was actually a situation of panic.
Sure.
But
yeah.
alhamdulillah, it went.
Alhamdulillah. Yeah.
Any other question?
Excellent case, Dr. Abdul Salam. Actually, when the balloon broke down, and you see there was a part which was coming out from the left main, and the guide was away from the balloon. So you just try to engage as you said, there are many options. So to me, the most easiest one is that you just engage the guide and trap it.
You are very right, sir. The thing is that I think again, there was a lot of panic. I think some wrong manipulation also has happened. It shouldn't have actually come out right from the beginning, but actually everything came out, and we are stuck.
And the guiding was 6 or 7 French guiding.
It was 6 French.
6.
6 French. All right. Thank you very much. Thank you. Yes, please.
As far as I understood, you snared the balloon in the ascending aorta. There may be a dangerous situation with stroke in that case. I prefer to do that in the descending aorta instead.
Okay. Right. Thank you very much for that feedback. Any other comment? All right, thank you very much.
Thank you. What about should we study and something should be done after the procedure that the balloon must have injured the left main stem, and then the patient might come with the left main stem thrombosis due to the injury in the left main. Is it? What is the opinion of panel about this? Should we have done IBUS or something else to study that, whether injury has occurred or not?
I think IOS should be done post-procedure.
So I will call the presenter of the last case of this session, Mariam Ismail, challenging CTO case. Owaise Shams. Owaise Shams can come and present the case in place of Mariam.
Assalamu alaikum everyone. I am Dr. Owaise Shams from Interventional Cardiology Unit, Liaquat University Hospital, Hyderabad. Actually, this case was performed before COVID by Professor in a CTO workshop by the Professor Umar Goktigan Sahab. He was a primary operator there, and along with him is Dr. Mohammad Kashif Sheikh Sahab. He was fellow with him. So, on behalf of them, I am presenting this case with their permission. It was really a challenging CTO. So the patient was of 56 years old, smoker, hypertensive male with family history of coronary artery disease. He was having CCS3 angina. He was on beta blocker, nitrates, and calcium channel blockers with EF of 55%. Coronary angio was done, which shows RCA CTO, LAD, and circ was non-obstructive. So bilateral femoral approach was taken, bilateral injection was given, and which shows the RCA CTO and LAD and circ, which is non-obstructive. RCA has at the proximal, there was a blunt cap, proximal cap with more than 20 mm, ambiguous coarse side branches, and invisible collaterals, septal collaterals. And JCTO score was 3. It means the procedure success rate is good. And the patient had good epicardial collaterals. So bilateral injections, bilateral femoral approach with 7 French JR4 and 7 French EBU 3.5. So we had 3 options to proceed: antegrade, retrograde from septal collaterals, or retrograde from epicardial collaterals. So because of blunt proximal cap and ambiguous course, it was decided to select a retrograde approach from the septal collaterals. The septal surfing was done with Seon guide wire, and fine cross microcatheter was taken. We did the septal surfing. But failed. Then we changed the strategy and to go through the apical epicardial collaterals. As we see, there are good epicardial collaterals. So first from the apical, it was the LAD collaterals. We tried. And through the circ also, but again we failed there. Then the other strategy, which is antegrade switchover, was taken, and the antegradely we took the fine cross microcatheter with fielder XT wire, and the balloon was anchoring in the conus branch. Redirecting multiple attempts was done. antegrade wire escalation was also done, and then Gaia second was taken. But we failed there, and then because the then retrograde approach from the circ epicardial collaterals was taken with Sion wire, and fine cross microcatheter was taken again. These are the we succeeded to cross the lesion in the RCA. Then exchange the wire to Gaia second. Although crossed the lesion, but failed to enter the guide. Then we did the antegrade dissection re-entry with fielder FC distal in the PDA and pre-dilate with the 3015 NC balloon. And stented with 3.523 Zion's expedition in proximal RCA on antegrade wire. Because the wire first go into subintermally, then into the lumen. So here there was no reflow distally because the wire was we found that wire in the subintimal plane long distally, and at this point the patient developed chest pain. Then immediate retrograde wire re-entry in the guide. Yes, please. Ultimately wire externalized and exchanged to RG3. Then 3.5 Zion's expedition is stented into the mid RCA. Then this was the result after stenting to the mid RCA. Then the 3.538 Zion's expedition is stented into the distal RCA. Post dilate with the NC3 3.54 from distal. Then a successful PCI to RCA CTO was done, and this was the final result. So take home message is antegrade versus retrograde approach should be switched over according to the situation, and patience is the key to success. Thank you.
Any questions and comments? I think though very few people in the world can do like these. This case is not Dr. Umar has patience and speed and planning of doing these cases, kind of cases. Then you have every kind of thing. Epicardial is not working, and then the antegrade, and then retrograde with other septal branches, and then you put the stent in and subintimal, and then recross that. It's a lot of work to do. It's huge. I think it must be 2-3 hours.
Yeah, maybe if you allow me. I was assisting Professor Umar Optical in this case. That time I was working as a fellow with him, and I believe that was a kind of great chance to me to work with him. At every step, what I was feeling is this case is going to be abandoned at this stage. And next moment he starts another approach. The second approach failed. I thought now this case is over. Now he moved to third approach. So that day was an important day to learn actually how one has to be patient in doing it. It took almost 4 hours. This case took almost 4 hours. I remember. And I mean that's I would like to ask Dr. Owaise, do you think why any inventory that you would need to cross epicardial collaterals? I mean, every time you were using Sion wire, we were using.
We do not have at that time like SUO wire.
So this is one thing, that SUO wire was not probably it was best for epicardial collaterals.
Can we use IVUS to penetrate the distal cap? to make it simple?
I may not be convenient, suitable for this because side branch is too small to accommodate. So, you know, we need a side branch to go and then for pullback. So, you know, I don't think it will happen. This is truly ambiguous cap, I believe.
Any other comments? Thank you very much. This is the time to close the session. And we have very good cases of left main bifurcation and complication at the end. I think the last case is summarizing all the techniques of CTO. The start with Dr. Anna and end with Dr. Omar Gotkin case. Thank you very much.
With this, we thank all the panelists, especially Dr. Omar Gotkin, for giving us a player. So there is an important announcement to make. We have seen all the 30 cases from the fellows. By tonight, we are going to shortlist the best 4 of them when we are done with the scoring. And the 4 presenters will be intimated. They will have to present these cases again tomorrow. And the prizes will be distributed in the closing ceremony.